Retinal detachment. What keeps retina attached? Forces that keep retina in place against choroid include intraocular pressure, choroidal osmotic pressure of extracellular proteins, interphotoreceptor matrix, and retinal pigment epithelial pump. Retinal detachment. Fluid accumulation and separation between the sensory retina and the retinal pigment epithelium. Types of retinal detachment include the following: rhegmatogenous retinal detachment, retinal break, vitreoretinal traction or fluid vitreous, tractional retinal detachment. Vitreoretinal fibroproliferative membranes pull the retina. Exudative retinal detachment, retinal or choroidal conditions disturbing retinal pigment epithelium or blood-retinal barrier. Rhegmatogenous retinal detachment. Etiology: posterior vitreous detachment. It is the separation of posterior hyaloid from retinal attachments. Areas of strong vitreoretinal adhesions include vitreous base, margins of lattice degenerations, cystic retinal tufts, paravascular retina, margins of optic disc, and chorioretinal scars. Etiology of posterior vitreous detachment. Age-related posterior vitreous detachment, 63% more than 70 years. Aphakic eyes, intracapsular cataract extraction, 84%. Extracapsular cataract extraction, 40%. Intact posterior capsule. Earlier age in myopes, trauma. Age-related posterior vitreous detachment. Pathogenesis. Insidious, starts with vitreous syneresis in perifoveal macula, gradually progresses and may produce retinal tears. Weiss ring. Glial tissue formed as the detached posterior vitreous strips from optic disc edges. Vitreous gel remains attached at vitreous base. Vitreous hemorrhage. Ruptured retinal vessels crossing tears. Avulsion of superficial retinal or prepapillary vessels. 50 to 75% associated retinal tear. Retinal breaks associated with PVD. Full thickness discontinuity of the neurosensory retina. Posterior vitreous detachment. 15% of acute symptomatic posterior vitreous detachment. 70% of acute PVD associated with vitreous hemorrhage. Tear is associated with rhegmatogenous retinal detachment in 25 to 90% of cases. Retinal breaks associated with PVD. Types: flap tear, full thickness rand due to vitreoretinal traction. Giant retinal tear, flap tear extending more than 90 degrees. Dialysis, full thickness disinsertion of retina at ora serrata, related to blunt trauma. Etiology: trauma. Hole, round full thickness atrophic discontinuity, not related to vitreoretinal traction. Cataract extraction. Rhegmatogenous retinal detachment. 2 to 5% post-intracapsular cataract extraction. 0 to 1.4% post-extracapsular cataract extraction. 20% with vitreous loss. 4% post-capsulotomy. 6% in myopes. Characteristics: multiple small peripheral tears along posterior vitreous base. More extensive, involve macula, 50% within first year post-cataract extraction. Peripheral fundus lesions predisposing to retinal detachment. Etiology: penetrating keratoplasty with vitreous loss, 2.4 to 3.6%. PPV, 3 to 6%, breaks posterior to sclerotomy site. Inadvertent scleral perforation, squint surgery, SBP, retrobulbar peribulbar injection, SR bridle suture. Blunt trauma, dialysis, 75% of tears, usually supranasally. Schwartz syndrome, trauma, rhegmatogenous retinal detachment, secondary glaucoma due to photoreceptors outer segment clogging the angle of anterior chamber. Penetrating injuries, retinal detachment follows transvitreal fibroproliferative membranes. Retinal lesions not predisposing to rhegmatogenous retinal detachment. Paving stone degeneration, retinal pigment epithelial hyperplasia and hypertrophy, peripheral cystoid degeneration. Pathology. Neural retinal atrophy affects outer segment photoreceptors. Apoptosis is an important mechanism of cell death. Subretinal fluid, serous fluid, blood, inflammatory cells, malignant cells. Proliferative vitreoretinopathy. Glial cells and retinal pigment epithelial cells proliferation on inner and outer side of detached retina and vitreous face, forming membranes. Membrane contraction results in fixed retinal folds, equatorial traction, inner non-pigmented epithelial detachment, retinal shrinkage, and reopening of retinal breaks and recurrent detachment. Classification of proliferative vitreoretinopathy. Grade A. Vitreous haze, vitreous pigment clumps, pigment clusters on inferior retina. Grade B. Wrinkling of inner retinal surface, retinal stiffness, vessel tortuosity, rolled irregular edge of retinal break, and decreased vitreous mobility. Grade CP 1 to 12. Posterior to equator in clock hours, focal, diffuse or circumferential full-thickness folds, subretinal strands. Anterior to equator in clock hours, focal, diffuse or circumferential full-thickness folds, subretinal strands, anterior displacement, condensed vitreous strands. Complications of chronic rhegmatogenous retinal detachment. Demarcation lines, retinal pigment epithelium, proliferation at posterior edge of neural retinal detachment with SMM membrane formation. Ring-Schwile, retinal pigment epithelial proliferation posterior to ora serrata. Intraneural retinal cysts, intraneural space with a small diameter neck and larger cyst. Dystrophic intraretinal calcification. Tractional retinal detachment. Etiology. Proliferative vitreoretinopathy, proliferative diabetic retinopathy, sickle cell retinopathy, retinopathy of prematurity stages 4 to 5 disease, familial exudative vitreoretinopathy, and post-traumatic. Exudative retinal detachment, shifting subretinal fluid. Etiology, choroidal tumors, uveal melanoma 75% exudative retinal detachment, choroidal hemangioma and choroidal metastasis, retinoblastoma. Intraocular inflammation, uveitis, Harada's disease, sympathetic uveitis, posterior scleritis, pars planitis, central serous chorioretinopathy, idiopathic uveal effusion syndrome, nanophthalmos, malignant hypertension, preeclampsia and eclampsia, disseminated intravascular coagulopathy, and collagen vascular disease.